If you or someone you love is taking a blood pressure pill called Atenolol, and millions of seniors are, this video could be one of the most important 10 minutes you spend this year. Because what the clinical evidence has been showing us for over a decade is something most patients on this medication have never been told. Atenolol may be lowering your blood pressure numbers on paper while increasing your risk of stroke and death at the same time. The numbers are not subtle. In a landmark randomized trial involving over 9,000 patients, people taking atenolol had 25% more strokes than people on a different blood pressure medication, even though both groups had nearly identical blood pressure readings. And in a separate massive trial involving nearly 20,000 patients, the atenolol group had such dramatically worse outcomes that researchers stopped the entire study early.
These are not minor findings buried in a footnote. They are headline results from landmark research that has fundamentally changed how cardiologists think about blood pressure treatment. The problem is that far too many prescription pads still haven't caught up. I'm Dr. Anthony Miles, and this channel exists for one reason: to take the most current evidence-based medical research and translate it into plain, practical information that adults over 60 can actually use. If you want to stay ahead of outdated advice that could be putting your health at risk, hit subscribe right now so you never miss a critical update like this one. Now, let's get into exactly what you need to know about atenolol. The medication I'm asking you to question today goes by two names. Its generic name is Atenolol. Its brand name is Tenormin. It belongs to a class of drugs called beta blockers. These drugs work by slowing the heart rate and reducing the force of each heartbeat. For decades, atenolol was considered a gold standard first-line treatment for high blood pressure. Doctors prescribed it constantly. Patients trusted it faithfully. Nobody questioned it much. But the science kept moving forward, and what it found should concern every senior still on this drug. Here's the core problem. Atenolol works by telling your heart to slow down. In younger people who have had a heart attack, or who live with heart failure or certain irregular heart rhythms, slowing the heart can genuinely be life-saving. But for an older adult taking it simply to reduce blood pressure, the story is completely different. As we age, our arteries naturally stiffen and lose flexibility. Our cardiovascular system needs the heart to respond quickly and efficiently to changes in demand, like standing up from a chair, climbing a few stairs, or even digesting a meal. When you pharmacologically slow that response with atenolol, you are not supporting a stiff-aging cardiovascular system. You are adding an obstacle to it. Blood has a harder time reaching where it needs to go, including your brain. Think of it this way. Imagine a fire station where the crew has been given something that delays their response time. The alarm still goes off, but help arrives slower. In your body, the alarm, whether it is a sudden drop in blood pressure when you stand or a surge in demand during mild exertion, requires a fast cardiac response. Atenolol blunts exactly that response. Take a moment right now and think about how long you have been on your current blood pressure medication. Drop the number of years in the comments below. You may be surprised how many people in this community have never had a single medication review since their original prescription years ago. Now let me walk you through the clinical evidence because this story is built on solid science. The LIFE trial, the Losartan Intervention for Endpoint Reduction Study, was published in The Lancet and followed over 9,000 patients aged 55 to 80. Half were given atenolol, half were given losartan, which belongs to a different class called ARBs. Both groups achieved almost identical reductions in blood pressure. The numbers on the monitor looked the same, but the outcomes were dramatically different. In the atenolol group, 309 patients had a fatal or non-fatal stroke. In the losartan group, only 232 did. That is a 25% reduction in strokes just by switching the drug, with the exact same blood pressure reading. This tells us something critical that most patients are never told. The number on the monitor is not the whole story. How your medication achieves that number matters enormously. But here is what genuinely stopped me when I went deeper into this research. The ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial, enrolled nearly 20,000 patients and compared an atenolol-based regimen to an amlodipine-based regimen. This trial was stopped ahead of schedule by its own safety monitoring committee, not because atenolol was working too well, because the atenolol group was experiencing significantly higher mortality. The committee concluded it was no longer ethical to keep those patients on that medication, and the damage did not stop there. A 21-year follow-up of ASCOT patients, published in the European Heart Journal in 2024, confirmed that the people who had been on amlodipine instead of atenolol continued to have fewer strokes and lower cardiovascular death rates more than 2 decades later. The protection was lasting, so was the harm. There is also a 2014 study published in Geriatrics and Gerontology International that tracked community-dwelling older adults with hypertension over many years and found that atenolol use was independently associated with higher long-term mortality compared to other antihypertensive treatments, not just higher stroke rates, higher death rates overall. Margaret was 68 when her doctor prescribed atenolol after her reading came in at 162/96. Her numbers came down, and she assumed the medication was working. What she did not connect to the pill was the crushing fatigue she felt every afternoon, the brain fog that made her lose words mid-sentence, and 2 episodes of dangerous dizziness when she stood up too quickly. Her daughter, a nurse, finally pushed for a dedicated medication review. When Margaret was transitioned gradually and safely to lisinopril, an ACE inhibitor, the fatigue began lifting within 3 weeks. A cognitive evaluation 6 months later showed measurable improvement in her processing speed. She told her daughter she felt like herself for the first time in years. What happened to Margaret has a clear biological explanation. Atenolol slows the heart rate. When you stand up, your heart must accelerate rapidly to push blood upward against gravity. When that response is pharmacologically blunted, blood pressure in your brain drops for a brief moment. That is the cause of the dizziness, the lightheadedness, and the falls. Falls are the leading cause of injury-related death in adults over 65 in this country. Orthostatic hypotension, the drop in blood pressure upon standing, is a documented and serious risk of atenolol in older adults, and it is often dismissed as just getting older. The American Geriatric Society, which publishes the Beers Criteria, the authoritative guide to potentially inappropriate medications for seniors, specifically flags this drug class for careful reconsideration in older patients. That is not fringe opinion. That is mainstream geriatric medicine. Before I give you the exact steps for your next doctor conversation, there is one more effect of atenolol that most patients are never warned about, and it may be affecting your thinking right now. Harold was 73. He had been on atenolol for 9 years. His wife noticed he was slower in conversations. He was forgetting names, misplacing things, and feeling mentally sluggish in the afternoons. His family was beginning to quietly discuss the possibility of early dementia, but a medication review led to a carefully managed switch to amlodipine, a calcium channel blocker. Within 2 months, Harold's family noticed he was sharper. He was finishing his own sentences again. He was cracking jokes at dinner. The fog was not dementia, it was the drug. So here's exactly what you should do if you are currently taking atenolol. First, do not stop it on your own. Stopping a beta blocker abruptly can cause a dangerous rebound rise in blood pressure, and in people with underlying heart disease, it can trigger a cardiac event. This is a medication that must be tapered under medical supervision. Schedule a dedicated medication review appointment with your primary care doctor or cardiologist. Not a routine checkup. A specific conversation focused entirely on whether atenolol is still the right drug for your age and health profile today. Ask directly, do I have a diagnosis that specifically requires a beta blocker, such as heart failure, a previous heart attack, or atrial fibrillation? If the answer is no, ask why atenolol is still your first-line treatment. Mention the LIFE trial and the ASCOT trial by name. Ask whether an ACE inhibitor, an ARB like losartan, or a calcium channel blocker like amlodipine would be a more appropriate choice for someone your age. If your doctor agrees a change makes sense, ask for a structured taper schedule. A safe transition typically involves reducing atenolol by 25 milligrams every 1 to 2 weeks while the new medication is introduced gradually. During this period, monitor your blood pressure at home twice daily, once in the morning before taking any medication and once in the evening. A clinically validated home monitor, available at CVS, Walgreens, or Walmart for $20 to $40, is all you need. Look for the words "clinically validated" printed on the packaging. Once you have successfully transitioned, ask your doctor about an appropriate target range for your age. The American College of Cardiology recommends a target below 130/80 for most adults over 60 who can tolerate it, though your doctor may recommend a slightly higher target depending on your individual frailty level. And remember that medication works best alongside lifestyle. Cutting sodium below 1,500 milligrams per day, achievable simply by reducing processed foods, canned soups, and restaurant meals, can lower systolic blood pressure by 5 to 6 points on its own. Research from the University of Leicester found that a 10-minute walk after each meal reduced blood pressure spikes in older adults by up to 8%. These are not replacements for medication. They are powerful tools that work alongside it. Here is the bottom line from today's video. Atenolol was once the standard of care for blood pressure. The science has clearly moved on. If you are over 60 and taking atenolol purely to manage blood pressure, with no specific cardiac diagnosis that requires it, you now have the evidence to ask your doctor for a better option. You are not being difficult. You are being informed, and that is exactly what you deserve. If this video made you think about your own medications, comment the word "reviewing" right now. If you are planning to share this with a parent, a sibling, or a friend who might be on this drug, comment "sharing" and tell us who you are thinking of. And if you have already been through a medication switch and want to share your experience, drop it in the comments. Your story might be what gives someone else the courage to make that call. Subscribe to this channel and hit the notification bell so you never miss an update like this one. Next week, we are exposing a popular supplement being heavily marketed to seniors for joint pain. But new research is raising serious questions about what it may actually be doing to your kidneys. That is a video you will not want to miss. I'm Dr. Anthony Miles. Stay informed, stay proactive, and I will see you next week.